Welcome to the third explainer in our SCDS Vestibular Physician Series, presented by Australian Dizziness Clinics. Today, we're zeroing in on a clinical presentation that really separates the true vestibular specialists from general practice.
We'll be looking at video 3 of our series, Clinical Features, from Autophony to Tullio. Every single symptom we're going to talk about today maps directly back to a predictable third window mechanism.
Let's start with a really powerful hook, something that should immediately raise your clinical index of suspicion. If a patient comes in hearing their own heartbeat, feels dizzy from loud noises, and actually has, quote-unquote, normal standard audiometry, well, they have SCDS until proven otherwise. That is the exact clinical picture we're going to unpack today. Here is our roadmap for today. We'll start with the broad clinical profile, dive into the specific vestibular and auditory features, and wrap up with a diagnostic triad you absolutely cannot afford to miss.
All right, let's jump straight into section 1, the clinical profile.
So SCDS produces a really distinctive symptom cluster that spans both the vestibular and auditory domains. And frankly, patients often present with a totally confusing mix of complaints. One minute they're talking about hearing internal body sounds way too loudly, and the next they're describing intense vertigo triggered by a loud alarm or even just coughing. But once you recognize this overarching division between auditory hypersensitivity and triggered vestibular events, you can start snapping the puzzle pieces together right there at the bedside.
Moving on to Section 2, Vestibular Features of SCDS. Let's look at how to actually elicit these abnormalities.
The absolute classic here is the Tullio phenomenon. This is where loud noises directly drive the endolymph to produce a characteristic upbeat torsional nystagmus. Why? Because that third window allows pathological coupling of inner ear pressure, meaning sound waves are literally deflecting the cupula in the superior canal. You can test this easily at the bedside using a 512 Hz tuning fork or just a loud trigal rub. The patient will often tell you they experience brief vertigo and acelopsia. You know, that visual blurring or image jumping that is perfectly time-locked to the sound.
Equally fascinating is the Henneberg sign. This proves that simple pressure changes in the ear canal can paradoxically stimulate the vestibular system. If you introduce positive pressure in the middle ear, say by using pneumatic otoscopy, it drives fluid amplifugili in the superior canal, and that produces the exact same type of vertigo and nystagmus as the Tullio phenomenon. It's a fantastic bedside demonstration of a highly pressure-sensitive vestibular pathway that, in a healthy ear, should be completely isolated from middle ear mechanics.
Now here is a really elegant trick for your bedside exam. Contrasting a nose pinch against a glottic valsalva yields opposite nystagmus directions, which gives you incredibly powerful lateralizing data. A nose pinch raises middle ear pressure, driving fluid ampullifugally. On the flip side, a glottic valsalva raises intracranial pressure, pushing the fluid ampullopedally. It's just a brilliant way to confirm a third window and pinpoint exactly which side is acting up. But we have to remember, it's not always explosive vertigo. Never overlook chronic disequilibrium. This can be the dominance and highly confusing presentation for patients with bilateral or subtle dehiscence. Many won't report massive vertigo from a loud sound. Instead, they complain of persistent postural instability, a constant unsteadiness, or just generalized brain fog. This is massively underrecognized. If you're only hunting for dramatic Tullio signs and Henneberg signs, you are going to miss these insidious presentations entirely. Let's pivot to Section 3, Auditory and Autophonic Symptoms. Time to look at the other half of the third window effect. Patients will frequently describe something super bizarre. They hear their own internal bodily sounds loudly. This is autophony. Because the third window enhances bone-conducted self-sound, patients might hear their own footsteps echoing in their head, their voice might sound hollow, or they might literally hear the sound of their own eyes moving. You'll also frequently see unilateral pulsatile tinnitus, where the arterial pulsation transmits directly to the labyrinthian fluid, perfectly in sync with their heartbeat. And finally, they present with a very specific low-frequency conductive hearing loss.
And when you look at their audiogram, it's a real eye-opener. You can clearly see the classic low-frequency air-bone gap paired with genuinely supranormal bone conduction. Notice the gap between the thresholds, especially in those lower frequencies, between 250 and 1000 Hz. What's wild is that the bone conduction thresholds might actually be negative, literally better than 0 decibels. Standard clinical audiometry often misses this because it just doesn't test below 0 dB, but that supernormal bone conduction is the direct result of acoustic energy shunting right through that pathological third window.
Which brings us to Section 4, the pathognomonic diagnostic triad.
If you take away anything today, let it be this triad. Let's see how it builds. Step 1, you listen to their story, the hollow voice, the loud heartbeat, the autophony. Step 2, you look at the audiogram and spot that low-frequency airborne gap. Now, step 3 is the absolute linchpin, intact stapedial reflexes. If this were a true middle ear problem causing that airborne gap, the acoustic stapedial reflexes would be gone. But in SCDS, the middle ear is perfectly fine, so those reflexes remain perfectly intact.
And here is exactly why this matters so much. Recognizing this exact triad prevents you from misdiagnosing the patient with otosclerosis and sending them for completely unnecessary middle ear surgery. A low-frequency airborne gap often screams otosclerosis to an ENT or audiologist, but if you miss the intact reflexes and the autophony, that patient might end up getting stapes surgery. Not only will the surgery fail to fix their hearing, it can actually make their vestibular symptoms significantly worse. Remember, any low-frequency conductive hearing loss with intact acoustic reflexes is a giant red flag. You must investigate for a third window lesion.
This specific clinical profiling perfectly sets up our next explainer. Next time, in video 4, we'll build a convergent, high-confidence diagnostic approach. Now that you know what to look for at the bedside, we'll dive into the 3-pillar framework, combining clinical symptoms with physiological tests like cervical and ocular VEMPs and high-resolution CT imaging to create a foolproof diagnostic pathway. Before we wrap up, I want to leave you with a thought. Are you totally confident you wouldn't miss the subtle, chronic signs of SCDS in the very next dizzy patient who walks through your door? Keep that pathognomonic triad top of mind. Thank you for watching this explainer. To explore more similar topics regarding dizziness, vertigo, and imbalance, and to access clinician and patient resource materials, visit AustralianDizzinessClinics.com. Please subscribe and leave a rating, and we'll catch you in the next one.